in Singapore General Hospital recently celebrated our bicentennial anniversary. It was supposed to be a big event. It was a big event, but we would have hoped that it would be a physical one. Due to COVID, it was done virtually. We operate about 3,000 joints every year, and unfortunately, 1% or up to 1% would have some sort of infection. Let's start with a case before we move on to discuss the various investigations and treatment modality. So this is a 70-year-old male, fairly independent, diabetes mellitus but well controlled, ischemic heart disease treated, and a previous thoracolumbar spine surgery. Right shoulder hip replacement was done. It was complicated by delayed wound healing, and the wound managed to heal in the end. 3 months post-operative, he complained of right hip pain persistently with limb length discrepancy of 3 centimeters. X-rays were done, and he was told that there was medial migration implant. He was prescribed custom orthotics for the limb length discrepancy. 6 months after the next operation, a partial revision hip surgery was done. Femoral stem was replaced, the cup was not changed, and the intraoperative culture grew MRSA. 5 years after the first operation, X-ray showed loosening of the cup, and he was prescribed bisphosphonate, and this resulted in a contralateral atypical fracture of the femur, and this was nailed. At our first clinical consultation, which was about 8 years after the operation, he presented with right hip startup pain, which was progressively worsening, centered over the groin, and he was unable to ambulate without analgesia. On examination, the right hip did not show any sinus tracts. The previous cup was healed, and there was no surrounding cellulitis. However, there was limited internal rotation due to pain, and there was a limb length discrepancy of 1 centimeter. To the right, CRP were not elevated. ESR was a little bit on the high side, 35. We did an ultrasound guided aspiration, and this gave a positive synovial result. And it was also noted unhealthy seroprevalence fluid on anterior hip joints. Cultures, aerobic, anaerobic, TB, gram stem were all negative. This is the X-ray, so you can see that the femoral stem is well fixed. The cup, cemented cup, was loose with radial loosened lines, all 3 zones. Right. So, in view of the positive synovial test, he underwent first stage revision to the hip replacement. We also encountered seroprevalence fluid in joints, which was in line with what the ultrasound aspirate yielded. We repeated another synovial test. It was positive. Therefore, the femoral implant was everything was explanted, and the Exotex CN spacer with a transplant extension was implanted to protect the ETO. Intraoperative culture grew Staphylococcus epidermidis. Okay, so this is from deep tissue culture. It's important to send many tissue samples for cultures. Right? And with antibiotic therapy, the ESR managed to normalize. The CRP managed to normalize, but the ESR remained elevated. So in my practice, as long as the ESR show the downward trend, and the ESR may take a longer time to normalize, I will do a hip aspiration, and if culture is negative, I would proceed with a second stage implantation. This patient underwent second stage revision surgery with a cartilage construct on the socket side, and a Wagner stem on the Wagner is a titanium tapered stem from Zimmer. It's a so moving on, we discuss the prosthetic joint infections. Okay. The risk factors are obesity, smoking, alcohol, drug abuse, and revision surgery. So in this case, we have revision surgery, and the patient had diabetes. The incidence is anything from 0.3 to 1.3%. The common organisms are Staphylococcus, MRSA, methicillin resistant Staphylococcus is getting more prominent. If it's early, 1 to 3 months after the operation, usually it's associated with wound complications. In this case, there was a delayed wound complication, delayed wound healing. Okay, that is a high risk for wound infection. If it's delayed, it's usually indicative of biofilm formation, and we have to consider explantation, right, to remove the biofilms totally. With late onset, which is 12 months from the operation, we consider low virulent, insidious onset microorganism or acute hematogenous PJI. The history, usually there's pain, stiffness, fever, and swelling, and we ask for recent or active bacteremia, especially with regard to the pneumonia, urine, or ulcers, infected ulcers in the lower limbs. This kind of examination, we are looking out for sinus tract, inflammatory changes, and limited RM stiffness. Usually, if the implants are loose, they have loss of startup pain. Instability, such as hip dislocation, could be a symptom of PJI. So this is the criteria, Musculoskeletal Infection Society diagnostic criteria for prosthetic joint infection. Major criteria are committing sinus tract or 2 positive synovial cultures. Right? Any one of these with 3 of the 5 minor criteria would suggest PJI, prosthetic joint infection. And these are the minor criteria: ESR-CRP, white cell count on aspirate or a leukocyte esterase strip, elevated polynuclear cell count, and 1 positive synovial culture, or more than 5 polymorph nuclear cells per high power field, X400 magnification, times modification. This is the modification by Pavlisi in 2018. Essentially, the major criteria are the same. He added the Sangeet test, which is the alpha defensing, and he stratified the minor criteria. So the important minor criteria are synovial cell count or leukocyte esterase or alpha defensing Sangeet. So if you have you don't have enough fluid from your aspirate, it is recommended that in addition to sending for cultures, you use the limited amount of fluid for synovial cell count or Sangeet test kit, the alpha defensing. These are the 2 most important minor criteria. If you have a dry tap, then you rely on intraoperative assessment evidence. And this is either positive virulence, as demonstrated in this case, or positive culture, which is also demonstrated in this case. Okay. So this is the Pavlisi WAOS clinical practice guideline. Okay. ESR-CRP interleukin-6 have strong evidence, right, with high sensitivity and specificity. Okay. Interleukin-6 is expensive and not usually done here, but most labs will do ESR-CRP. Tumor necrotic factor alpha and peripheral blood leukocyte counts, they are not as strongly sensitive or specific. The gold standard in diagnosis of PJI is that of joint aspiration, whether you do an ultrasound or CT-guided aspiration. And you send them for Sangeet test kit, as well as cell counts, differential counts. It is important to maximize the yield from this aspiration, because if you don't have a bacterial pathogen, then half the battle is lost already. Right? So it's important to maximize the yield, and this can be done by suspending antibiotics 2 weeks before the cultures. What I do is, once I aspirated the joints, I would inject the aspirate immediately into blood culture bottles. Right? So if you leave the aspiration on the table for a while, the fastidious organisms will have died, and you cannot culture them anymore. Similarly, if you put them in a specimen bottle without storing it, it's also these organisms can die very easily as well. So you won't be able to do anything. Radiological evidence would be quite late, because The signs of osteolysis, periosteal reactions, and implant insertion usually happens in the very late stages. PET scans and wound scans have weak evidence. CT or MRI, CT scan is good to assess for wound loss before the revision surgery. MRI to assess for collection if you want to aspirate. A frozen section has strong evidence, but you need to know which are the representative areas to send for histology, and you also need to have pathologists who can do the staining properly and give you a proper report. Okay. It's important to take multiple tissue. I take at least 5 to 7 tissue from many sites, right, different areas for cultures with prolonged incubation. Okay, so these are the evidence for ESL and CRP. Strong evidence for ESL and CRP, 97.6%. Synovial cell counts and percentage neutrophils are also very important. I take the cutoff as 2000, 1007 for WBC and 65% for polymorph nuclear cells. Okay, this will give you 94% sensitivity and 88% specificity. Alpha dependency is getting very popular nowadays. However, it's expensive, right? The good point, the advantages are the test is unaffected by prior antibiotics, ongoing sepsis and inflammation, and there's rapid identification. Within 10 minutes, you will have results. Okay. Unfortunately, the results may be affected by patients with active inflammatory arthritis and gout. This will give you false positive readings, or if you have a bloody tap, that would also give you false positive readings. Leukocyte esterase is an enzyme secreted by neutrophils. The test strips are used in synovial fluid. Use it for the UTI as well. Advantages are cheap, rapid, and it's a convenient test, but disadvantages are is affected by active inflammatory arthritis and gout, similarly resulting in false positive readings. Sonification is very useful to maximize the yield from our explanted implants. So we pass low-frequency ultrasound waves over prosthesis to detect the biofilm organisms. This can increase the yield by up to 30 times. After the investigations, we move on to the treatment modality. So there are 5 surgical options: debridement, antibiotics, implant retention, single-stage, 2-stage revision, right? Arthrodesis, and amputation. Okay. So, for example, a patient who is suitable for debridement, antibiotics, implant retention will be this patient with 1 week post-op persistently discharging wound. Okay, so you must be very aggressive with wound discharges. If it's discharging by 1 week, spare no attempts to debride it and send for cultures. Okay. Right? So in the debridement, you will do a proper debridement, and these are the biofilm busters that we use in our institution. Chlorhexidine, acetic acid 0.5%, hydrogen peroxide, 5% iodine. This will help to eliminate aerobic, anaerobic, fungal, and TB mycobacteria. Postoperatively, rifampicin is also another biofilm busters. We keep them on rifampicin for a while starting them on or continuing them on antibiotics that can target the pathogens. So in this case, the culture grew Pseudomonas aeruginosa. The patient finished 6 weeks of IV antibiotics, and he was disease-free thereafter. So the results for debridement, antibiotics, and implant retention, right, in this study is up to 89.2%. But these are the people with early infection, right? These are patients with about 1 week of wound discharge. They go in early to debride, so the results will be good in these cases. Okay. In these two other studies, right, the results are not so good. About 60% success rate, and the cases that failed there are the Staph aureus infection, right? Staph aureus infections are not good for there. Okay, in our paper, we have 106 patients. The success rate was about 70%. We found the predictors of failures were MRSA infection, pre-op ESR, and repeated DARS. So if you have failed one DAR, implant retention is not advisable for you to repeat another one, because you're just delaying the inevitable of 2-stage operation, and you are allowing the biofilm to form even more. So the success for the factors for success for there would be short duration of symptoms. All right. Factors for failure will be staph aureus infection, patients with poor ASA. For single stage, this will be an example of a patient who is stable, 5-week post-op, complaint of persistent right knee pain and CRP being persistently elevated. Okay. Knee aspiration grew Staphylococcus aureus, okay, from the knee tab, and she underwent a single stage operation. So a single stage operation is not one operation; it's actually 2 operations in one. And for the first part, all the implants are explanted. Okay, we give a good wash with the ribofilm blasters. Okay, and then we stitch up the patient, right, to redrape, regown, and use another set of instruments for the second stage, for the re-implantation. Okay, so it's actually a 2-in-1 operation. Right? It's not advisable to use the same instrument for your explantation and your re-implantation. Okay. Now, so the following patients will require 2-stage. 67-year-old patients with non-tuberculous mycobacteria. This is a very aggressive bacteria, very different from your TB bacteria. This non-tuberculous mycobacterium will require multiple repeat spacer exchanges. And you see, even with the repeat spacers exchanges and the IV antibodies, he developed patellar pathological fracture from infection. So this patient required a year of antibiotics, repeat stage 1s, before we finally put in the revision implants. Another case for 2-stage, 65-year-old multi-organism PGI. You can see that there's a lot of osteolysis, there's loosening of the implants, right? Okay. So in this case, we have a very unusual organisms, right? Unusual organisms, and the patient will require a 2-stage procedure right before we put in the revision implants. So what is the evidence out there for single versus 2-stage revision? In this meta-analysis, there's actually no difference if you choose the patients wisely. No difference in outcomes between a single stage and a 2-stage procedure if you choose your patients wisely. Okay. Right. So these are the patients requiring arthrodesis, MRSA, PJI, patellar rupture, extensor mechanism loss, and massive skin necrosis. Right. So you need to remove the implants. I use a nail to arthrodese the knee first for the flap to take. And once the flap is taken, infection is cleared, you can proceed with arthrodesis. Can be done using an X-fix, can be done with plates, or you can use an intramedullary nail. So this is a 2-year post-op arthrodesis. Right. And finally, the amputation cases, right? The 70-year-old female, eczema, very poor skin condition, diabetes, and she had a megaprosthesis with periprosthetic infection. Tissue cultures have been growing staph aureus and fungal. Fungal bacteria is another bad news. It's very hard to clear. So this is a megaprosthesis. We try to do a limb salvage procedure, remove the implant, and use a static spacer, but we were unable to get rid of the infection. In the end, she had to go for amputation, right? So lastly, this is our technique for treating infected periprosthetic fracture with protrusio. Okay, you can see that there is a periprosthetic fracture around the bipolar implant, and there's a protrusio into the pelvis. Right? Tissue cultures grew anaerobic organisms. We reported this technique, infected THL, Karpowski 3 defects in the socket after explantation. What we did was during the first stage, when we removed the implants, we gave a good wash, we wound grafted the protrusio with cancellous bone chips. Then we put a cement spacer, cover the bone chips and hold it in place. And during the second stage, we retained the induced membrane over the bone chips and used hemispherical cuts without a need for augments or cages. So this is an example of how it's done. We put some bone grafts in the protrusio with a cement spacer, and after that, we put in a hemispherical cup without any augments or cages. And 5 years post-op, you can see the remodeling in this case. Okay, this 1 year and 5 years post-op. So in summary, it's always important to have a strong intestinal suspicion for infection. If it's painful, you will try to exclude infection. Right? Debridement, implant retention, antibiotics for useful for early post-op infections. Be aggressive with the wound debridement. If the wound is discharging, be aggressive going early to debride the wound. Acute hematogenous setting will be top of your mind, right? It's appropriate for implant retention. Single stage for known organisms, good soft tissue cover. 2-stage for difficult organisms such as fungal infection, non-tuberculous bacterial MRSA, right? And if you have soft tissue loss. Arthrodesis for sensor mechanism losses and amputation in my practice is usually after two stages, right? So thank you for your attention.